I have 11:45, so let's go ahead and get started. Welcome. This is our session on Remote Patient Monitoring 201. And just a friendly reminder that if you have questions, we would love it if you could use the event app instead of the Zoom chat box, if you can recall how to do that. If you go to this session and do the Ask a Question part of that. There will also be some live polling in this session. And so in your EventMobi app as well, there is a join live poll. So if I could just remind you to pull up the event app and kind of put it next to your Zoom window because you will be going back and forth a little bit for that. And so for this session, our presenter is Bonnie Britton. I am director of the Mid-Atlantic Telehealth Resource Center, and Bonnie has been my go-to person for all things remote patient monitoring. She has been doing this for many years, and she is one of our consultative service partners at Matrix. And so without further ado, Bonnie, take it away.
Okay, thank you, Kathy. Um, good morning, soon to be afternoon to everyone today on this Friday. Happy Friday. I'm really happy to be here to talk with you about remote patient monitoring. I'm not sure how many people were in the 101 that just previously ended and now into 201. I hope that those that were in 101 are here as well today. So what we're going to focus on during this session is to really work with the participants to be able to make sure that in this session you know how to design our RPM conceptual model, that you can design the clinical workflows and the processes that you will need to be successful in remote patient monitoring, articulate the advantages and disadvantages of the various conceptual models, and then determine the RPI financial return on investment. Now, I have to say, when we first started planning this session pre-COVID-19, I was going to break people out into groups and actually go through and develop models and clinical workflows and let everybody, present those to the other groups. And obviously, we can't do that today, but I do want to have enough time at the end for people to ask questions about these key concepts, because a lot of organizations really focus on the technology when it comes to remote patient monitoring, and technology is important. I'm not going to say that it's not. However, to me, it's not the most important thing. All the devices are FDA approved. They basically all do the same thing. The biggest difference is their software capabilities in managing those alerts. And to me, the critical piece where organizations make the greatest mistakes is not going through the process of what we're going to do for the next hour and 15 minutes. So the first poll question, if everybody could pull up their app, please identify the type of organization you work for, whether it's a home health agency, a hospital, health system, medical clinic, federally qualified health center, rural health center, insurance carrier, or other. Okay. Okay, perfect. Do you currently have a remote patient monitoring program? Yes or no? Got it. Thank you. All right. Okay, further poll questions. If you do not currently have an RPM program, which is 75% of you, are you planning to implement an RPM program within the next year? Yes or no? Okay, got it. So that's exciting to hear that out of the participants that said no, they don't have one, that yes, they want to plan to implement in a year. I think that's the um, highest poll I've seen in quite a while. That's very exciting. Are you or do you plan to monitor the patients with internal staff? Okay. All right. Are you or do you plan to manage install, deinstall like devices? Okie doke. Excellent. Thank you so very much. So the first thing we're going to talk about, or this presentation is going to discuss, are the critical components of remote patient monitoring. And the first one that we're going to talk about is identifying the use cases. then how to develop that conceptual model, actually going to tell you how to develop your clinical workflows, how to design your remote, your return on investment and your scalability plan, and then some on technology. So use cases. Use cases can be looked at from a clinical or a financial perspective. If it's solely a clinical perspective, then you would look at things such as your patients with hypertension, patients with high hemoglobin A1C levels, uncontrolled diabetics, uncontrolled heart failure, uncontrolled COPD, patients that are post-CABG. The other patient population I would put up there are patients with cancer who are going through chemotherapy, who those regimens may or may not affect, or that may affect, excuse me, their weight as well as their glucose readings, even if they're not a diabetic. And so really any clinical use case would be any patient population that you're working with that has an uncontrolled chronic condition. And you're specifically trying to improve that clinical outcome for the patient. Most of the organizations that implement remote patient monitoring are looking at it from a financial perspective. So originally, health systems and hospitals were utilizing remote patient monitoring as a cost avoidance for less than 30-day to reduce less than 30-day hospital readmissions, which would affect their reimbursement over the course of the year. Now more and more hospitals and health systems are looking at this as a way to decrease those less than 90-day hospital readmissions, decrease ED usage, and self-pay population is very interesting. We have, I have in the past done a lot of evaluation on remote patient monitoring programs, and one of the areas that stands out significantly from a financial perspective are self-pay patients. I was asked to do an evaluation of a very large 3-year remote patient monitoring program in the state of Nebraska. And we found that Medicaid patients, they had the least financial incentive, followed by Medicare patients, and private insurers, that those patients, the hospitals were making money off of that patient population. Well, what we found is that the hospitals in that state were writing off a tremendous amount of money on the self-pay population, because the self-pay pop, which is there's still a lot out there, and even patients that have Obamacare, the deductible is so high, it is a long time in recovering that money from those patients. And I'll give you an example. I was on Obamacare 3 years ago, and one morning I slipped in my tub and face planted on the floor and had a skin tear, significant, over my right eye. I went to the emergency department. I was there less than 2 hours. Pediatric facial plastic surgeon stitched the 50, 60, 70 stitches, how many ever stitches I had. And my deductible was $10,000. My bill was $9,000. So it took me a very long time to pay that $9,000 bill. So just because somebody's insured doesn't mean that they have the money to be able to pay. So I would always recommend hospitals and health systems to look at their self-pay population, because there's a tremendous opportunity to be able to lower all those millions and millions of dollars of write-offs with patients. So I'm sure that all of you in the audience are aware that you have to work very, very closely with your finance department to get them on board and supportive of the program, to obtain their commitment. We'll talk more about this later, but obtain their commitment that they will pull data to do a return on investment analysis. Now, most importantly is to develop your conceptual model. When I talk about conceptual models, I'm talking about device management, installation, de-installation options, as well as the monitoring. So when you start a program, you need to determine internally how are the devices going to be managed? Who is going to receive that inventory? Where is it going to be stored? You're going to need a clean location to have that equipment stored. Once a patient is identified, who's going to pull, test, and pair devices if that's needed, but they're absolutely going to have to pull and test those devices, and then put it in a bag or in a carrying bag or in a container to take to the home for installations. And then also once the patient is discharged off program, that those devices have to be collected. They have to be in a sealed container or large trash bag for at least 24 hours, placed in a dirty area, and then someone's going to need to clean and retest each of those devices. So you need to think about, is that something that you have the resources and the space to do? Look at other options. I'm going to give you a few examples. So we've been working with, I've been working with a large health system in Eastern Kentucky. And when we first started talking about device management, they said, oh, that's easy. We're going to just outsource that to the DME company because they have the vans, they have the drivers that will go out there and be able to do these things. They've got the space for storage. They're used to taking care of equipment. And it was a great idea. Did it work? No, it didn't. Why did it not work? The reason it didn't work is there was no financial incentive for the DME company to provide those services. So it always kept being put at the bottom of the DME driver's responsibilities. So if you're going to give this to another department in your organization, then you have to also provide them with financial incentives or money to be able to manage that. When I was at Vidant Health, we cover 10 hospitals in 29 counties in Eastern North Carolina. And so we made a decision there that biomedical department, we paid for biomedical technicians to receive inventory, to store, to test, to pull, etc., and do all the refurbishment of the devices. So that's something, you have to look at your organization. If you're a small, well, FQHC, you may not have the personnel, the resources. Health systems, you may or you may not. So you really need to strategically think through how those devices are going to be handled. And once you've done that, then you will look at, okay, we're going to do that. So then you've got to make a decision. Do you want to do this yourself, or is this something that you would like for the device vendor to do? Either way is fine. Of course, if the device vendor is going to do that, then there's going to be a fee per set of devices for keeping that inventory, pulling, testing, and pairing devices if needed, and then shipping those devices to the patient's home with a return label so that those devices can be shipped back from the patient's home at no cost to the patient for them to refurbish. So you can either do this yourself or you can outsource it. Either way is fine. Installation options, you need to think about this. The gold standard is in-home installation, where someone would go to that patient's home, they would install the devices, they would demonstrate how to use the devices and train the patient, and they would collect one set of readings, that installer would. Those readings later would be suppressed from the software since they weren't the patient's readings. And then the patient would return, demonstrate and collect at least 2 readings per device to make sure they're comfortable with that, and then patient competency validate them. I highly recommend patient competency validation forms so that if Joint Commission or other regulatory agencies come into your organization and say, okay, tell me how this patient was educated and how you know that they can utilize this technology. That's always nice to have. The other options are if the program is based in a primary care provider clinic, a federally qualified health center, or a rural health clinic, you can actually provide the devices to the patient there. If they're in the clinic, you can do the training on the devices and provide the devices while the patient's in the hospital. And then your other option is to outsource that. So some organizations go, I don't want to manage the devices. I want the vendor to ship the device directly to the patient, but I want one of our staff to go into that home to do this installation. Other organizations may say, I don't want to do either of those things. And so you would outsource all of that. Or the organization may say, we want to do all this ourselves. And there's no right or wrong here. It's really based on the resources you have available, the people and the time, and distance. A lot of programs are in very rural areas in the country, and mountainous areas where it takes a lot longer to travel from house A to B to be able to do these installations. So I highly recommend that you think through that process of what is best for your organization. Okay, then the in-source monitoring, you can do the monitoring yourselves. The really advantage to that is that the nurse that's monitoring probably has an established trusted relationship with the organization and possibly the patients. Some organizations are unwilling for a third party to access their EMR. So it's completely okay to in-source all of your monitoring. The one caveat, and I have a slide to show this a little bit later, is a lot of people don't understand the volume of the alerts that patients generate. And every alert that is generated, someone has to call that patient to validate that reading and then conduct an assessment. Or if they go, no, it wasn't my reading, then you have to go into, well, let me make sure you understand, don't let anybody else use the devices, etc. So I've seen organizations that initially in-sourced their monitoring that turned around and outsourced it just because they had no idea of the volume of alerts and phone calls that were necessary. The monitoring ratio between a nurse and a patient, whether that's in-sourced or outsourced, is 1 RN to 85 to 100 patients. And that person's going to be super busy. Outsource monitoring, that was allowable under the CPT code 99457, January 1st of this year. The advantages of that is the organization does not need any additional FTEs. There's your staff. You will only receive validated actionable data, which may need a medical intervention. And it removes the need for the customer to provide non-clinical RPM services. So the non-clinical RPM services are a big part of remote patient monitoring. So patients get up in the morning, they empty their bladder, they weigh. They go to the kitchen, they check their blood sugar if needed, take their medications, have their meal. They wait an hour, they can sit in their easy chair, they wait for 10 minutes, rest, take their blood pressure and their oxygen level. Anytime a reading is high or low of the alert parameters that have been set for that patient, then someone has to call that patient and validate indeed that the reading is the patient's. Then secondly, if it is the patient's, they have to validate that they just followed those steps that I just described. If they did not do that, then someone needs to re-instruct them on the appropriate way to collect their data on a daily basis. They may say, well, I did all of that, and then you would go into your nursing assessment. The other thing is when patients don't take a reading, then someone needs to do a follow-up adherence call with that patient. So most nurses go through and they handle all of their alerts. They contact the patient, they get all those things taken care of. Then they look to see who has not taken readings. And then they start calling those patients regarding taking their readings. A lot of times they're not going to answer the phone. A lot of times you will leave a voicemail. You will get patients occasionally, but I can tell you patients hate these adherence calls because the patients aren't doing the reading. There's a reason they're not doing the readings, and it's difficult to get them to share with you what that is. The number one reason patients don't take their readings is they've been given a device that does not relate directly to their chronic condition. For an example, my blood pressure normally runs low. That's my norm. If someone gave me a blood pressure device, my physician, and said, I want you to monitor your blood pressure every day, I can tell you I wouldn't do it because it's not related to any issue that I'm experiencing. The other thing on the adherence calls is when you can get them on the phone, they say, well, I took those readings. Then someone has to provide tier 1 troubleshooting on those devices, such as, can you look and see on your cellular, how many bars do you have? Can we pop a battery out of that scale and put the battery back in? Can you open the back of that blood pressure meter and pop out that battery and put it back in? So all of these things, alert validation, instruction on the use of devices, adherence calls, and tier 1 troubleshooting has to be done as part of RPM, and really an RN doesn't need to provide those services. So that's just another area to think about. Then here's an example. We started calculating this for a health plan that we work with. So initially they had 18 patients, and over a 3-month period, those 18 patients had a total of 717 alerts. So someone had to call for each one of those alerts. Did the patient have multiple alerts? Sure they did. Some didn't, some did. So there weren't 717 calls, but there were 717 alerts that had to be addressed. Of those 717, only 16 of those alerts needed to be escalated to either the primary care provider or whomever the organization wanted that escalated to. That's less than what we have found. Only between 1% and 2% of all alerts end up being escalated for medical intervention and or escalation to 911. So the customer here, out of those 717 alerts, their staff only were responsible for follow-up of 16 of those alerts. So it eliminated a lot of work for the organization, from the organization, and it averted 701 alerts from the customer or the organization. So that's just something to think about. I see it all the time. People don't understand, or the nurse that's been assigned to monitor these patients don't understand the volume of those alerts, and that every alert you have to call that patient for, and you need to do that and respond, conduct an assessment, escalate it up to the provider within 4 hours of that alert as best practice. Okay. Then the next thing, which is super important, is creating a clinical workflow for patient identification and referral. It's critical that when you develop RPM workflows, that you have a very clear understanding of your current workflow so that you can then ask the following questions that we're going to go through and answer them based on your current workflow so that you're incorporating RPM into your existing workflow, not changing your existing workflow to incorporate RPM. Super important. So usually when I'm doing consulting with an organization, I ask them who is the best person or persons to identify the patient. If you're in a hospital setting, that might be the discharge planner. It may be a case manager. If it's a home health agency, it may be the start of care nurse. It may be the intake nurse. If it's a clinic, it may be the primary care provider of that patient. If it is a payer, then run a list of reports of the most high cost, high utilization members for that insurance provider. So really think about who's the closest to the patient to identify based on your goals and objectives and what you're trying to accomplish. So then the next question is, who is the best person to meet and or call the patient and explain the program and obtain verbal consent? So in a hospital setting, if it's a discharge planner, then they identify the patient. They're probably the best person to go into that hospital room and explain the program and get verbal consent. Whereas if you're in a clinic and the provider identifies the patient, then that provider, more than likely, highly more than likely, is not going to go into the patient room or call the patient to explain the program. They're going to assign that over to an RN or an LPN or a medical tech to do that. If it is a home health agency, it may be the start of care nurse because they're in the home for the very first time to explain that program. So who's going to identify? Then once they're identified, who is going to either physically meet with the patient and or call the patient, explain the program, and obtain verbal consent. And let's talk about explaining the program. In the 101, we talked about having opt-out inclusion criteria, meaning that to present your program as a extension or part of your current services that you provide to your patients. Oh, my mind just went blank. Don't you hate when that happens? Lord have mercy. Kathy, help me here. What was I last saying? My mind just went blank. Anyway, you've got to meet with the patient and explain the program. The inclusive criteria. That was what I was talking about. So you want it to be an extension of your services. And when you meet and call the patient and explain that, you need to use language such as, our organization has a program that is free of charge, that has proven to help patients with your condition stay home, and it is part of the services that we now provide. You want to stay away from using terminologies such as devices and technology and all of those things. Stay away from that and focus on it as a service, because that's truly what it is. It's a service that you're providing the patient. Yes, the devices provide you the data to be able to provide that service, but it really needs to be focused on the services. And then who is the best person to then, so the patient says, sure, I'll be glad to do that. So who is then the best person to refer that patient? And what I mean is going into your vendor software and actually putting in the patient's name, their phone number, their address, some demographic information. It may be the discharge planner. It may be the social worker. It may be the start of care nurse. It may be, it's an administrative type person that does that. So it really depends upon, again, your setting, but somebody's got to be responsible for going into that software and placing that referral in. Why is that so important? That's how the whoever's going to do the pulling and testing of devices and going to do the installations, whether that is your staff internally or a vendor shipping the devices, that's where they're going to be triggered that they need to go to the next step. And then who's the best person to identify devices? This one, again, is super critical. I never recommend giving a kit of devices to a patient who doesn't need every device that's in that kit. Because if you do, you're going to have a lot of issues with non-adherence. So you're going to have your staff or someone's staff spending a lot of time making phone calls to patients regarding adherence. And I can tell you from experience, patients will, if they haven't done their reading and they see that I'm calling them, they're not going to answer the phone because they don't want to hear it. I mean, you're totally in their home and they're in control. And so give the patients the devices they need, not a full kit of devices unless they have, you know, COPD, heart failure, you know, diabetes, etc. So that one's super important. So that way you will have a clinical workflow that is mapped out so it's very clear who's going to identify the patient, who's going to meet and explain the patient and the program to them, get that verbal consent, who's going to refer, who's going to place that information in the patient software, portal software, and then who is going to identify the devices that are needed that would be placed in that software as well. And then the next workflow is patient installation and education. Again, we have talked about if you decide to install these devices internally yourself, then when that person goes into the patient's home, obviously they're going to have to pull the technology, test it, pair it if needed, put it in a bag or a container, put it in the clean side of their trunk. They have to have a clean and a dirty section within their vehicle. When they get into the patient's home, they're going to get a written authorization. It doesn't have to be informed consent. It can just be a written authorization for that patient to sign. I always recommend providing an educational sheet on the proper data collection technique, not so much how to use the devices, but wake up in the morning, empty your bladder, stand on the scale. You know, telling them exactly the sequence of how they should do things during the day. Then the installer would demonstrate how to use the devices, then and actually collect one set of readings by the installer. Then the patient would demonstrate, and collect two sets of readings per device, and then patient signs the competency validation form. The other thing that's important here that I just realized is not on the slide is while you're in the home, contact via phone, unless you have a tablet with you, contact whoever's going to be monitoring the patient and assure that the data did indeed transmit. Because the last thing you're going to want to do is leave that home, go back to your organization and find out that the data didn't transmit. Then you have to go back to the home again to do that. So that's super important. Now, if you outsource this, the written authorization is much more difficult to attain. It's not, there's no requirement that you have to have a written authorization. The educational sheet for proper technique can be placed in the box with the devices. And then the device vendor would instruct the patient on how to use those devices. The patient would then collect two sets of devices and the device vendor would verify that the readings did transmit. they're probably not going to be able to sign a competency validation form. So those are just some things to think about. Best practice is in-home installation, but you also know for the setup, the CPT code 99453, it's only a national average of $21 for a setup, which is obviously too low if you are in-home installation, and it barely will cover the cost of shipping directly to a patient's home. But it's a start. We're glad it's there, and hopefully CMS will listen to feedback that's coming to them so they better understand what best practice is. Okay, alert monitoring and validation. So a registered nurse is going to monitor the patient data Monday through Friday. They're going to respond to the alerts within 4 hours. And what I mean by response is that they're at their screen, they see an alert, they call the patient, they validate that alert. If the alert's not valid, they're going to instruct the patient on device technique and instruct the patient to recheck their readings. Then, so that is the first thing that is done. And then when the alerts are valid, an RN will conduct an assessment, utilize C-field change methodology, and I'm going to describe that in a minute, to create long-term behavior change, and then provide focused patient education on the symptoms or the issues that you discover during the C-field change process. So let me explain that a little bit. And for you that are on 101, you're hearing this again, but so sorry. But my mom died 5 years ago at the age of 93, and she had heart failure. And if I told her once, I told her 1,000 times, Mom, you can't eat Chinese food. Well, did she listen? No, that if education worked, we wouldn't be in the situation we're in today. So what did work was when we placed her on remote patient monitoring, her weight was up one day. The nurse called her and said, Miss Perry, I see your weight's up today. How are you feeling? And so Mom could see her readings. She was able to articulate how she felt. And then the nurse said, have you taken your medications? Yes, I did. She asked some other assessment questions. Yes, yes, yes. She said, what did you eat yesterday? And she said, I had Chinese for lunch. That was the aha moment. That's the moment where you tell the patient, okay, Ms. Perry, if you don't want to feel like this again, then let's talk about how to prevent that. And one way to prevent that is, I know as much as you love Chinese food, you're just not going to be able to eat it. And that's when Mom made the correlation between what she did yesterday and how she feels today. And that's when you can get those patients to make those connections. That's really when you see long-term behavior change. It's simply not just the education, even though that's important. And then you escalate any validated useful data up to the patient's primary care provider if the nurse believes there needs to be a medical intervention. And then you're going to need to document that encounter. So the activities on the previous slide and this slide all need to be completed within a 4-hour period for best practice. I don't know why that's there. And then you're going to need to have a discharge and deinstallation workflow. First thing you need to talk about is the length of monitoring. How long are you going to monitor these patients? Is it going to be, if it's a hospital and they're trying to decrease less than 30-day hospital readmission, their first instinct is going to be, well, let's only monitor them 30 days. If it's a home health agency, they're probably going to say, we're only going to monitor them for their the amount of time that they're within home health. You know, it's usually a 60-day episode of care. It may be that it's a payer and they're looking at the long-term financial gain and health of their members. So it may be indefinitely. It may be one insurance company, they have all patients that are referred to the remote patient monitoring program. that patient completes a patient activation measurement tool, which is a scientific validated tool that measures level of engagement. And for them, the lower the score and the lower the level of activation, there's 4 levels of activation, 1 through 4. Level 1 are those patients that believe that their health care is the responsibility of the provider. They're not engaged in their care. They're told they have brand new onset diabetes and they don't change their behaviors. They don't seek to get into educational classes, dietary classes, etc. So any patient that scores a PAM level 1, those patients are automatically enrolled in remote patient monitoring for 6 months. If they're a level 2, they also are enrolled for 6 months. A level 3, which is a patient that's more engaged, they are put on the program for 3 months. A PAM level 4, which is somebody that has a new diagnosis and they're learning and reading and signing up for classes and doing everything humanly possible, we monitor those patients for a month. Having said that, though, not a single patient in a PAM level 4 has been discharged after a month. It normally takes 78 days to create long-term behavior change, which is bottom line everybody's clinical goal. So you really need to talk about the length of time monitoring and what is going to work best for your goals and objectives, your organization, and your patient populations. The other thing that I recommend, whether you're insourcing the monitoring or you're outsourcing that monitoring, that there be clinical calls or huddles every 2 weeks to discuss discharge. Has the patient met their clinical goals? Are they adherent to their medical regimen? Have they achieved what we believe they need to achieve for discharge? So that it's a clinical decision discharge versus just okay, you've gotten your 60 days in and we're going to discharge you. Some patients that are put on for 60 days and 30 days, they're ready to be discharged. So you really need to focus that discharge on the patient ability to meet their goals. And then you're going to have device retrieval and refurbishment. Are you going to do that yourself? Or are you going to send somebody out into the home to get that equipment? It has to be sealed in a plastic container or a trash bag for 24 hours, placed in the dirty location of your car or vehicle, taken to the dirty location within your organization to sit for 24 hours, and then somebody needs to physically clean the devices and put it back on the shelf. So you can do that internally, or that is something that your device vendors can do. So again, it's super important to think through each of these things to make the best decision for your resources and your capabilities. Okay, return on investment. So anytime you're working to start, I think one of the very first conversations regarding remote patient monitoring, even before you get into all of these workflows and trying to figure out patient populations, is what is your return on investment going to look like? And what data do you need to collect? And the frequency of that data collection. And will you have a control group? Will you have an RPM group that's going to be measured against a control group? Will the patient act as their own control group? So most organizations that I've worked with to help them on that return on investment have made the decision to have the patient as their own control point. So let's say that Bonnie Britton was admitted onto remote patient monitoring today, July 10th. So that organization would then pull for either a month or 3 months of financial data and utilization for Bonnie Britton for the 1 or 3 months time period prior to being placed on remote monitoring. So at Vidant Health, we monitor the patients for 90 days. So we pulled 90 days worth of data for the time period before remote monitoring. Then we monitored the patient for 90 days. And at the end of 90 days, the health system pulled the financial data for the 90 days that we monitored that patient. And then, which was overkill, but we did it. Then after discharge, we collected 90 days worth of data. So what we were able to look at is, okay, prior to RPM in 3 months or a month, whatever you decide, the financial and the utilization and the cost associated was X amount. During, at Vidant Health, we decreased the utilization and the financial amount by 67 and 68% respectively. And then what we found after discharge from remote patient monitoring, the trend for utilization and the reduction in costs actually continued on a downward trend. So based on your goals and objectives, and then let me say one more thing before I go back to that. The other thing that we were able to do at Vidant is we had a heart failure group. We had heart failure patients who were eligible for remote patient monitoring. And of that total population, we had a group that agreed to be monitored, to participate, and we had a group that refused to participate. So we were able to compare the utilization and financial data on the heart failure patients who participated versus the ones who did not. And what we found is the patients that, heart failure patients that did not participate, their readmission rate, less than 30-day readmission rate was 28%. The group of patients who participated in the program, their less than 30-day readmission rate was 7%. So there's multiple ways that you can do that, but it's super, super critical that you collect data and analyze that data. Then having a comprehensive evaluation plan, that can include patient satisfaction, it can include patient engagement, it can include did the person increase on their patient activation measurement tool, etc. And then probably the most important thing on this slide is getting a commitment from your CFO. When I started the outpatient program, the post-discharge program at Vidant Health, we had a 700-unit program. The very first thing I did is I went directly to the CFO and obtained the commitment from the CFO that they would indeed collect data and evaluate the program from a financial perspective. And then once we had that commitment, we were able to then develop our data collection plan and our evaluation plan. So, poll questions. What data does your organization collect to evaluate remote patient monitoring? Is it hospitalizations, ED visits, hospital length of stay, financial data, number of skilled nursing visits, number of contacts with the patient?
The responses were 18% each for hospitalizations, ED visits, hospital length of stay, financial data, and 27% said number of contacts with patients, and nobody said number of skilled nursing visits.
Right, because there were no home health agencies. Okay, excellent. What time period do you collect your data? 30 days prior and during, 60 days prior and during, 30 days prior, during, and after, 60 days prior, during, and after, or other?
So we had 25% say 30 days prior and during, 25% say 30 days prior, during, and after, and 25% say 60 days prior, during, and after, and then 25% other.
Okay, awesome. I referenced this, hospitalizations when I was at Vidant during remote monitoring, the 3-month time period, we decreased hospitalizations by 67%. Bed days decreased by 68%. And this is the what I was referring to. The patients who had heart failure but refused was a 28%, less than 30-day readmission rate compared to 7%. I know I'm kind of running out of time. I'm going to skip the technology and go straight to questions.
All right, I don't see any questions in the actual app question box, but since we only have about 25 of you all, we'll go ahead and allow you to unmute yourself. So if you want to ask a question live, go ahead and just unmute yourself and jump in.
Hi, this is Carol, but I just want to thank Bonnie for her great presentations. I was on the 101 and on this one too. And, you know, we're just going to start doing RPM, and I'd ask that question about just having the AI without the interface. You know, we're an academic medical center, so people think it's so easy for the back end people to figure this stuff out for them, right? So
right. So Kathy, you weren't on the 101. Her question was: there's an organization that has artificial intelligence that they want them to use, but they don't have any devices and a software platform to do that, and are really relying on the health system to do that. And it seems disjointed because usually the artificial intelligence lies within the software of the vendor, so that the AI works in that situation. So I don't know, Kathy, if you have anything to add to that, but it seems to be a little bit disjointed to me.
Yeah, and I have heard that comment before from other people. So I think you know, some of it is, yeah, you're not alone.
I thought it was special.
So I know Donna had a question.
Yes, hi Bonnie, thanks. This is a great presentation. I appreciate it. We have a remote patient monitoring program that is grant funded. We've had a couple grants from HRSA to first do remote patient monitoring for care transitions, and then we moved that into the primary care practice, providing remote patient monitoring and care management for patients with congestive heart failure. And one of our challenges has been to get our health systems to commit to sustaining remote patient monitoring when the grant funding is over. We've done some rigorous evaluation that shows significant return on investment, but the reimbursement just doesn't cover the actual cost of providing the monitoring. And so I wondered if you had any suggestions for making the case for sustainability.
Sure. So if you've been under a grant, you either purchase the technology or you lease the technology, correct?
Correct.
So now do you own the technology?
No, it was leased, and the health system provided the clinical monitoring staffing.
So at the end of your lease, you didn't own your technology?
No, they didn't. It was on
Wow.
a lease, so.
Wow. So then my recommendation would be I would go out in the market and I would find a vendor whose per patient per month is less than your reimbursement rate. The national average is $69. So there are many vendors out there who are lower than $69 per patient per month, so that at least it's paid for and you have a little profit margin. The other thing is you need to, if you don't have the internal staff to pay to do the monitoring, I would highly recommend you look for outsourcing that, because there are companies that can provide those services for less than $54 per patient per month. And so at least if you implement the program, you're not going to have a huge profit margin, but at least it's paid for. And then I would also find a vendor that at the end of that 3-year lease, it's your equipment. I mean, that to me is super critical because you paid for it over the years. It should be yours. So that would be my recommendation. And if, if I can help you in any way, following this to kind of go through the math of it, I'll be happy to assist in any way I can.
Great. Thank you, Bonnie. And we have time for possibly one more question if anyone wants to jump in.
Yes, I have a question. Can everyone hear me?
Yeah.
Yeah.
Yes, hi. This is my name is Raul Morero, HIT manager for Tennessee Primary Care Association. We serve all of the federally qualified health centers in the state of Tennessee. A lot of different things with telehealth, and just now starting to jump, considerably into the remote patient monitoring space. Looking at different companies in my role of what I can provide to our health centers of what's out there. I'm sorry, Bonnie, I'm going to put you on the spot quite a little bit, but just want to get your honest opinion. An organization that I just spoke to yesterday is offering something from remote patient monitoring top to bottom to implement it for our health centers at no cost. Does that sound too good to be true, or have you heard of something like that in different spaces?
I've never heard of it at no cost. What I have heard is that there are some vendors who say you can do a 3-month pilot at no cost. But I can pretty much assure you that once you have to start paying, that payment you didn't make for 3 months is going to be loaded in there.
No. They're talking about something with agreements with Medicare and Medicaid, and that's how they look at their profit. But as far as no cost for the device, no cost for implementation other than time is how they're selling it to us.
I'd really love to have a conversation offline
Sure.
about that, because I've been in this 23 years and I've never had a deal that good. But there are a lot of companies that now are coming out that have cellular devices embedded in the peripherals, which are lowering the cost dramatically because you don't have to have a transmitting hub. And I don't know of any remote patient monitoring vendor who does not charge a monthly fee for their platform and communication services. I mean,
yeah,
that ranges from $20 to $55 per patient per month.
Right. That was surprising to me also. That's why I wanted to make sure I asked. I have your contact information. I can certainly reach out to you offline. Thank you for that.
Certainly.
Great. And thank you so much, Bonnie. We are out of time and we appreciate all of you joining. A reminder to please fill out the session evaluation that is in your event app for this session. And thank you again for joining, and thank you, Bonnie, for a great presentation. And definitely you can contact Bonnie through the app as well as through her direct email. So thanks again.
Thank you, everyone. Bye-bye.